Hi to everyone watching. My name is Emily Naoum. I'm a dual-trained obstetric anesthesiologist and critical care physician, and I practice at Massachusetts General Hospital. I'm here to discuss peripartum management and escalation of care in the high-risk patient. I hope to make this talk relevant for any anesthesiologist who cares for obstetric patients, who's interested in gaining a deeper understanding for how pregnant women experience complications. I also want to speak to what we can do in our role on the labor and delivery floor to help provide and advocate for the most appropriate and safest level of care for these women. To quickly go through goals for this session, I'll review current trends in maternal morbidity and mortality, ICU admission characteristics in this population, briefly review pregnancy physiology and how that affects our ability to detect deterioration in pregnant women, discuss bundled care, and identify opportunities for non-traditional critical care administration models in these patients. So let's start with some epidemiology. It's hard to discuss maternal critical care without reviewing severe maternal morbidity. These are CDC-defined unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. There are 21 indicators with conditions in various systems as noted here. The rate of morbidity is rising over the last 2 decades by almost 200% overall since 1993. Now, this increase is mostly driven by blood transfusions, but even when you exclude those, the rate of morbidity increased by about 20% over these years. Severe maternal morbidity is associated with both ICU admission as well as mortality. So let's talk about risk factors. A study done in 2013 of more than 850,000 women using Medicaid data looked at conditions that are associated with severe maternal morbidity. The conditions were weighted to create a comorbidity index. I'll talk a bit more about this later as a way to flag at-risk patients. Medical conditions associated with increased morbidity include chronic heart, liver, and renal disease, lupus, and HIV. Obstetric conditions include preeclampsia with severe features, multiple gestation, and prior cesarean delivery. Social risk factors that have been identified in other studies include public or absent health insurance, as well as lower education levels and lower incomes. And finally, significant racial and ethnic disparities have also persisted in maternal morbidity and mortality, and this gap exists in every racial and ethnic minority category when you compare with deliveries among non-Hispanic white women. Maternal mortality is a very real problem. The US maternal mortality rate is quoted at 17.3 per 100,000 live births, and this is based on a study of pregnancy-related mortality by the CDC. This has substantially increased over the last 3 decades from 10 in 100,000 in 1990, which is closer to the current mortality rate in the UK. An important point to be made here is that several large-scale studies have shown that ICU admission and maternal mortalities have been deemed potentially avoidable in a significant number of cases. 2 of the most common factors include inadequate knowledge and or skills by staff and lack of recognition of seriousness of condition by the care team. This figure comes from a retrospective study of maternal mortality in the US. It demonstrates that pregnancy-related mortality increases with maternal age. The authors identified the leading causes of maternal death in the US are cardiovascular conditions, which contribute to more than a quarter of deaths, followed by pre-existing illness, sepsis, and hemorrhage. Of note, this study did not include psychiatric conditions, which have been increasingly highlighted as a leading cause of maternal morbidity. A recent article that it did include psychiatric diagnoses found that the number 4 leading cause of pregnancy-related death in the US is perinatal mood and anxiety disorders. Reviewing these trends, the rates of maternal deaths from hemorrhage, hypertensive disorders, and anesthesia complications have decreased over time. However, I'll draw your attention to maternal sepsis with a mortality rate that remains around 12% over the last 3 decades. This figure comes from the UK Embrace, which is a collaboration that conducts surveillance and inquiry into maternal deaths. It shows similar trends to the US report, with the leading cause of death also being cardiac disease, followed by thromboembolism, neurologic morbidity, and here you'll note they actually included psychiatric disease, and this is the 4th leading cause of mortality. Following this, we see the pre-existing illness and sepsis that we see in higher numbers in the US maternal mortality study. Importantly, they found that deaths related to infection actually increased from 2012 to 2018, again, emphasizing the need for better detection and management of sepsis in this population. Inequality in maternal health and outcomes remains an ongoing battle. This figure comes from the CDC, and it demonstrates that there are clear racial disparities in the incidence of pregnancy-related mortality, with non-Hispanic Black women experiencing more than twice the rate of mortality when compared with non-Hispanic white women. Variability in the risk of death by race and ethnicity may be due to several factors, including access to care, quality of care, prevalence of chronic disease, structural racism, and implicit biases. So how often do women who experience morbidity require ICU admission? The estimates of ICU admission are challenging, and this is due to lack of consistency in the definition. Overall, 1 to 3% of peripartum women require ICU admission or critical care services in the US each year. And this is comparable to rates in other developed nations, the majority of these admissions being postpartum. The causes of ICU admission actually do not differ significantly in high income versus low and middle income countries, but there's a significantly higher mortality rate in low and middle income countries. Hemorrhage and hypertensive disorders of pregnancy account for the majority of maternal ICU admissions, although the exact case mix actually differs widely in each country and even within different regions. This is likely multifactorial, related to differences in prenatal care, socioeconomic and environmental factors, surgical practices, and regional ICU admission guidelines. This figure shows the causes of maternal ICU admission in high-income countries as identified across several studies between 2006 and 2019. These were all retrospective analyses of admission diagnoses in the US, Canada, Netherlands, Italy, France, and New Zealand. Risk factors for ICU admission have been identified using retrospective studies. This table comes from a study of obstetric ICU admissions in the state of New Jersey that highlights significant risk factors for ICU admission, including hypertensive disorders of pregnancy, cesarean delivery, multiple gestation, and hemorrhage. This study looked at over 18 million live births in the US between 2012 and 2016 using National Center for Health Statistics and live birth records. The authors developed a predictive model that looked at factors associated with maternal ICU admission, and they identified, again, cesarean delivery, hypertensive disorders, and induction of labor as the highest risk factors for critical care needs. Other notable risk factors include a BMI greater than 50. Again, I want to point out that this study showed Black and Hispanic women have an increased risk of ICU admission compared with white women. I mentioned before that we would circle back to severe maternal morbidity. We discussed the 2013 study that created the comorbidity index score, where various maternal and obstetric conditions are assigned a weighted number and the total score is calculated. This score was primarily calculated to estimate morbidity, but this figure shows that one of the secondary outcomes of that study was ICU admission, which is also found to be associated with a higher comorbidity index, or CMI score. Simplified tools have allowed us to determine these scores clinically, and they can be used to make a universal baseline assessment of every patient on a labor and delivery floor. A higher initial CMI score draws attention to those patients who may require close monitoring and help influence providers to escalate care more promptly. If you know that they're at risk of being sick, you may be more likely to tune into even subtle abnormalities when they develop and capture evolving complications earlier in their time course. Identifying patients at risk is particularly important given how many studies demonstrate much of maternal morbidity is potentially avoidable. The figure on the left here comes from a single center retrospective hospital study in Australia that looked at ICU admissions over the course of 2 years. They found that nearly half of ICU admissions for common diagnoses of hemorrhage and infection were potentially avoidable just with improved care. On the right is a prospective population-based cohort study from the Netherlands that looked at more than 2,500 women who experienced maternal morbidity. They identified that preventable morbidity was most commonly due to delay in recognition of symptoms and delay in treatment once the diagnosis was made. The most recent Embrace report noted that improvements to care may have made a difference in outcome in a surprisingly high number of cases of maternal mortality. You can see here for various diagnoses the percentage of deaths that may have been preventable. Hemorrhage, sepsis, and indirect causes were largely due to delays in recognition and lack of senior physician involvement. Epilepsy and stroke shared issues with gaps in pathways of care. Preventable deaths due to PE were largely due to errors in risk assessment. We're only human, but there's a lot of room for improvement overall to reduce maternal morbidity and mortality. We can trace many of these preventable scenarios to some common themes, including lack of recognition of illness, resulting in delayed treatment, lack of knowledge or supervision, and lack of protocols, resulting in failure to follow the standard of care. So why is this such a challenge? Well, no one can give a maternal critical care lecture without mentioning the physiologic changes of pregnancy. And what I'll try to do is tie this into the challenge of detecting critical illness. Cardiovascular changes of pregnancy are related to the hyperdynamic state. Increased cardiac output comes from an increased stroke volume and heart rate and increased contractility. SVR and PVR decrease throughout pregnancy, resulting in a lower overall blood pressure. Pulmonary changes include an increased tidal volume and increased anteroposterior diameter of the chest, resulting in a respiratory alkalosis compensated by renal bicarb excretion. There's a physiologic anemia of pregnancy due to a disproportionate increase in plasma volume compared to red blood cell volume. Most clotting factors increase, resulting in a hypercoagulable state. White blood cell count increases in pregnancy. Levels of immunoglobulins A, G, and M are unchanged, but humoral antibodies to certain viruses, including herpes simplex, measles, and influenza, are decreased. Renal blood flow and creatinine clearance increase throughout pregnancy, resulting in a lower serum creatinine. And progesterone has many effects on the GI system, including biliary stasis. The increased abdominal pressure and reduced lower esophageal sphincter tone increases the risk of gastric aspiration. So hypertension is usually not challenging to diagnose, and although hemorrhage can be elusive, it may be easier to detect than the one diagnosis that time and time again evades us, which is infection. So keeping in mind these physiologic changes, I want to reflect on various scoring systems that we have to detect sepsis in the general population and challenge you to apply them in the peripartum period. The SIRS criteria actually describes normal pregnancy physiology in 3 of the 4 values that we look at. These have been found to be very sensitive, but poorly specific in pregnancy. The Q-SOFA score is more specific, but the sensitivity has been found to be only 50% in studies with patients who have known sepsis due to how rare it is to have mental status changes and unreliable documentation of respiratory rates. So let's talk about the SOFA score. The SOFA score has been shown in the general population to predict ICU mortality based on several lab and hemodynamic parameters. Initial scores of 11 or mean scores of greater than 5 correspond to a mortality rate of greater than 80% in patients who are admitted to an ICU. Regardless of your initial score, an unchanged or increasing score is associated with an increasing mortality rate. For obstetric patients specifically, the total SOFA score does reasonably well for predicting severe maternal outcome, meaning ICU admission or death. It has the best overall performance for general complications and hypertensive morbidities. The one area of weakness is for obstetric hemorrhage. And this is because the total SOFA tends to underestimate the occurrence of a severe maternal outcome. This is really important to consider when you care for patients who you think may need an ICU admission. The lower score may cause ICU providers to underestimate how sick these people really are. Knowing the limitations of the score in pregnant patients can help facilitate a conversation with intensivists and advocate for admission when needed. Since there are no obstetrical specific scoring systems for now, the SOFA score can be used to predict the risk of developing organ dysfunction and help in decision making regarding the need for patient transfer. Given the limitations of standard ICU assessments and scoring systems in pregnant patients, comprehensive early warning systems have been developed specifically for obstetric patients. This includes the maternal early warning criteria, and variants of this have been studied and implemented across the world. The MU criteria require 1 or more of several physiologic triggers noted here to trigger a clinician evaluation and possible escalation of care. A case control study in 2018 looking at patients with maternal sepsis showed that the MU criteria performed significantly better than SIRS and Q-SOFA. Another score, the Modified Early Obstetric Warning Score, uses similar physiologic variables to the MU criteria, but with additional components that are noted here and different levels of trigger based on the degree of abnormality. A case control validation study looking at overall maternal ICU admission, so not just for sepsis, showed that the modified score had a high sensitivity and reasonable specificity when you use 1 or more red trigger values. To take a moment to focus on, again, one of the most challenging diagnoses in pregnant patients, I want to highlight the Sepsis and Obstetrics, or SOS score. It identifies women at risk of morbidity and predicts the need for ICU admission in patients with maternal sepsis. So similar to SIRS, Q-SOFA, and the MU criteria, this score uses physiologic variables and lab values, and it actually scales them based on how abnormal they are to generate a score. A score of greater than 6 is used as a cutoff for moderate care escalation and or ICU admission. This table here compares the statistical strengths of various scoring systems predicting ICU admission for sepsis, and it shows that the SOS score has the highest positive predictive value and the highest overall area under the curve. Importantly, it also has a very high negative predictive value, so it can reassure providers that patients who have a score less than 6 can most likely stay on the labor and delivery floor safely. Integrating these warning systems into clinical pathways has real appeal to standardized evaluation and early intervention in at-risk patients. This figure comes from a study published by a group in California where they reported nearly 120,000 deliveries after implementing this tool. It includes early warning triggers and pathway-specific recommendations to expedite treatments for the most common areas of morbidity. The group noted a statistically significant reduction in maternal morbidity when they compared baseline data compared to after implementation of the tool. Identifying patients who are developing illness is really challenging, and overcoming the cognitive bias that most of these patients are healthy young women who couldn't possibly be developing critical illness is another hurdle. These kinds of systems help to create a universal check-in for providers on the labor delivery floor to objectively evaluate patients and proactively manage complications to prevent morbidity. So this leads us into bundles, not because I think anyone needs to memorize every step, but rather so you can leave here knowing that bundles exist for the most common maternal ICU admission diagnoses. You can help to advocate to follow these bundles to ensure better adherence to treatment. And if all you can remember is that they exist, I hope that means that you can look them up when the time is needed. There are many bundles that are available, openly accessible, and some institutions actually have designed their own. The National Partnership for Maternal Safety and the Alliance for Innovation in Maternal Health have framework for bundles addressing many of the common ICU admission diagnoses. The idea is that these safety bundles provide a set of evidence-based guidelines to optimize care for these at-risk patients. Here on the right is an ACOG example of a checklist for management of hypertensive emergency. The standard bundle framework is shown here. Importantly, the response includes a standard protocol for management, and for most conditions, it dictates the need for provider notification within 15 minutes of an abnormal vital sign and treatment within 60 minutes. If patients don't respond to treatment, escalation measures are needed. The slide is very busy, but I want to highlight a sample bundle from the California Maternal Quality Care Collaborative, or CMQCC. This group has put together outstanding QI toolkits that have been instrumental in improving maternal outcomes. These guidelines have very thorough background literature in their toolkits and well-explained rationale with concise recommendations and pathways. On the left, we can see that it includes a reference for abnormal maternal vital signs, and this should look familiar after the last section of the talk. The bundle then emphasizes that if an assessment is abnormal and sustained, a provider must evaluate the patient and initiate treatment, including antihypertensives and magnesium. This also comes from the CMQCC, and it gives providers recommendations for antihypertensive therapy, and importantly, it ends with key parameters for consideration of emergent consultation with subspecialists and potential transfer of care. Having a set algorithm to define maximum limits of IV push medications is really important. Providers have biases and tunnel vision, and we have all been a part of patient care where these have contributed to a hesitancy to escalate care when it may have been appropriate. This tool can actually help to facilitate an objective discussion as to where a patient may be in her treatment and what she may require going forward. The National Partnership for Maternal Safety and Council for Patient Safety in Women's Healthcare published similar recommendations for bundled elements to improve care for women with obstetric hemorrhage. This figure comes from the bundle published by the CMQCC. It separates hemorrhage into stages based on blood loss and vital signs, and it outlines the baseline elements of assessment, medications, procedures, and blood availability. Here you can see stages 0 and 1. In worsening postpartum hemorrhage, stages 2 and 3 have escalation recommendations for patient evaluation, team involvement, medication and surgical interventions, and transfusion considerations. You can see that the assessment for a stage 3 hemorrhage includes a second anesthesia provider and an intensivist. Although many cases of postpartum hemorrhage can be successfully managed on labor and delivery, early mobilization of critical care resources and potential bed allocation can help to facilitate a smoother transfer of care if it's ultimately needed. Escalation of care for obstetric hemorrhage is most appropriate with ongoing bleeding, profound coagulopathy, need for frequent labs or transfusions, and any multi-system complication that stems from hemorrhage, like volume overload, TACO, trolley, or significant metabolic disarray. Monitoring capabilities vary amongst institutions, and appropriacy for ICU admission should be determined on an individual and system capability basis. Finally, I want to touch again on sepsis. The CMQCC proposes a two-step strategy for diagnosis of sepsis during pregnancy and postpartum. The first is a screening step, and it assesses for abnormal vital signs based on pregnancy adjustments and the white blood cell count. The second diagnostic step uses evaluation for end organ dysfunction with lab values, again, adjusted for pregnancy where needed. Integrated within this bundle are management recommendations. Clinicians should act quickly upon recognition of sepsis, and antibiotics should be administered within 1 hour. Women should be monitored for response or lack thereof. Actions based on meeting criteria for sepsis is outlined in this bundle, and it encourages close surveillance. ICU admission is recommended for patients who demonstrate clinical instability after appropriate initial treatment. Having a defined pathway for patients with sepsis helps enhance team coordination and align expectations for management. Patients who may require ICU admission are those who need frequent hemodynamic or lab monitoring, vasopressors, mechanical ventilation, or other invasive support. CMQCC defined criteria for escalation of care includes persistent hypotension after appropriate fluids, hypoxia, and depressed level of consciousness. The aim of these bundles is to improve the quality and consistency of care for the most common complications of pregnancy. Hypertension bundles have been shown to reduce time to treatment, and studies are ongoing to establish how that may have an effect on ICU admission and morbidity. Hemorrhage bundles have been shown to reduce morbidity, including progression of hemorrhage and transfusion needs. And finally, sepsis bundles have repeatedly been shown to improve early antibiotic administration with a clear mortality benefit. These protocols enhance communication and timely management of complications, and they can serve as cognitive aids for crisis management and excellent resources for clinician education. Now, I'll try to tie all of these critical care concepts into the clinical construct within which we need to work. As our pregnant patient population evolves into more complex patients with more chronic illness, we really need to consider how we can best provide well-rounded obstetric critical care to these women. So does maternal morbidity equal ICU admission? Well, this is a hot area of discussion. I want to share some interesting findings from a very recently published article looking at the epidemiology of severe acute maternal morbidity, or SAM, from the EPIMOM study. This was a prospective population-based study specifically designed to study SAM in 6 French regions. They had over 182,000 deliveries included, and around 2,500 women who had severe morbidity were actually analyzed. The definition that they use for maternal morbidity in this study is different than that which I discussed earlier from the CDC. This group defines SAM as a combination of 6 diagnostic criteria, which included things like major obstetric hemorrhage and severe preeclampsia, 6 organ dysfunction criteria, and 2 interventional criteria, one of which is importantly ICU admission. They found that 20% of women with this definition of severe morbidity were admitted to an ICU. Of these women, 1 in 7 had no other criteria for morbidity beyond ICU admission, meaning 1 in 7 women admitted to the ICU are essentially there for monitoring for potential decompensation. These women were more likely to have pre-existing illness and had shorter overall length of ICU stay and fewer ICU interventions than those women who had additional SAM criteria. This is really thought-provoking because it suggests that there's a subgroup of patients who are sick and may benefit from monitoring but will not need ICU-level intervention. Alternatives to ICU admission could include intermediate care units that provide enhanced nursing care and some elements of ICU monitoring, but in a less intensive environment. These are increasingly utilized in the non-obstetric population, but there's little data about peripartum care in this kind of setting. There are some financial implications for this level of care in terms of reimbursement, but they may have benefit in this group. So we're facing this quandary. Where is the best location to deliver critical care to obstetric patients, particularly those who aren't yet delivered? The advantages to delivering on the labor floor are increased physical space, familiarity with obstetric interventions, and access to operating rooms. On the other hand, the advantages of delivering in the ICU are immediate availability of ICU providers, advanced monitoring, and higher level interventions. The choice depends on the degree of patient instability and the interventions required. Maternal well-being should be the primary goal. Providers who regularly work in labor and delivery have the greatest familiarity with obstetric surgical interventions and medications which are not routine in the ICU, and close access to operating room facilities for potential delivery. This is a highly specialized patient population, and the majority of intensivists do not routinely care for pregnant patients, and especially not in the peri-delivery period. Those providers who do have experience with obstetric and anesthesia care to pregnant patients on a more regular basis should be available to provide direct or consultant care. Finally, recall that I mentioned that psychiatric illness is a leading cause of death. Depression and PTSD are very real complications from ICU admission, which I'll discuss momentarily. The importance of emotional attachment and maternal-fetal bonding must not be overlooked. The Embrace report highlights that critical care is a management modality. It's not a place. Prompt initiation and continuation of treatment is mandatory, regardless of where the woman is physically situated, and should not be delayed by lack of bed availability in an ICU. This is really an area where we as anesthesia providers can lean into our expertise of critically ill patients to serve our complex OB patients and participate with obstetric colleagues in team-based care. ICU admission does not come without drawbacks. Admission to the ICU in general is associated with poorer health-related quality of life, and this figure comes from a retrospective study of nearly 300 obstetric patients who were admitted to an ICU. It demonstrated that 20% of patients experienced impaired quality of life at follow-up, including worsened mobility, self-care, and pain. Psychiatric morbidity is also a significant consideration for ICU patients. At 1 year, up to 35% of patients experience depression and/or anxiety, and up to 20% of patients experience PTSD. Patients who have pre-existing psychiatric disease are particularly at risk. Further downsides to maternal ICU admission include separation of the mother from her child, which may affect maternal-infant bonding. And finally, at the collective level, admission to an ICU has substantially higher costs than admissions to other units. There are unique considerations for these patients regardless of where they are located for their care. Team management varies based on the needs of the patient, but in all cases should be multidisciplinary. Delivery planning and neonatal considerations also need to be made in those patients still pending delivery, and emergency equipment must be available for these women. A strong effort should be made to maintain the standard of postpartum care for these patients, even when they're admitted to the ICU after delivery, encouraging bonding and psychosocial support for the mother. Our main problem is when these patients exist in the gray area of the spectrum of critical illness. Sometimes, though, there are very clear indications for ICU admission. Mechanical ventilation, vasopressor support or invasive monitoring, ongoing severe bleeding, acute liver, cardiac, or neurologic failure all generally require an ICU admission. As I mentioned earlier, it's challenging to provide hard and fast rules for ICU admission given that different institutions have varying levels of monitoring and staffing capabilities. An alluring prospect is the idea of graduated escalation of critical care delivery. A nice article published in 2019 outlines the COSMIC paradigm. This is a 4-step early multidisciplinary consultation, automated surveillance, monitoring, and intensive care aimed at high-risk patients. The proposed concept is that these women are best managed on the labor and delivery floor with a remote ICU telemedicine service, except in extraordinary cases. This model provides a monitoring framework on labor and delivery that uses nurses with both ICU and obstetric training, ICU-level patient monitoring, and telemedicine ICU consultation in select patients to add an additional layer of vigilance for patients who may not otherwise be sick enough for ICU admission, but you still want to bring an ICU level of care to labor and delivery. Proponents of this model highlight the importance of immediate proximity to obstetricians, obstetric anesthesiologists, and the operating room. I want to close by taking a high-level view at maternal critical care. Preconception counseling and medical optimization is crucial in high-risk obstetric patients. Upon admission, patients should be assessed for risk of morbidity and continuously monitored for development of complications using maternal-specific early warning systems. If critical illness develops, there are bundles in place for common conditions associated with morbidity, and these emphasize a prompt assessment and treatment, multidisciplinary involvement of care teams, and escalation of care when appropriate. So to reflect on what we've covered, we have reviewed the trends in maternal morbidity and mortality, discussed ICU admission characteristics in this population, reviewed pregnancy physiology and how that affects our ability to detect deterioration in pregnant women, considered the benefits of bundled care, and identified opportunities for non-traditional critical care administration models in peripartum patients. Thank you for taking the time to listen this afternoon. I really appreciate the opportunity to speak. Feel free to email me with questions, concerns, or anything at all. Thank you again.